Good evening, everyone. I'm Andrea Foti, and I'm the Deputy Registrar and Privacy Officer at the RCDSO. Welcome to this evening's RCDSO Connect session. Thank you so much for joining us. This session has been approved for 1 point in Category 1. As a reminder, participants are required to attend for a minimum of 40 minutes to be eligible for the CE point. RCDSO Connect is an important way the college stays connected with the profession. These sessions create space for shared learning and thoughtful reflection on how we support safe and professional dental care in an evolving healthcare environment. Earlier this year, we saw the impact of that engagement at RCDSO Connect Ottawa, where more than 150 oral health professionals came together in person at the National Arts Centre for a session focused on professionalism and trust. We were pleased at that session to be joined by President Harinder Sandhu, Vice President Nalan Bhargava, and Executive Committee member Aaron Walker, whose perspectives help ground the discussion in both regulatory expectations and real-world practice experience. Events like the live session in Ottawa and tonight's virtual session are a central part of how the college engages with registrants across Ontario. That spirit of engagement is especially important right now, as the college is actively consulting on a new standard of practice on managing new patient requests. The consultation is now open. I see you've got a QR code on screen, and there'll be a link posted to the chat. This is a draft standard, and it reflects ongoing work to support fairness and consistency in how patient requests are managed, while recognizing the realities of practice capacity and access to care. We strongly encourage you to review the draft standard, share your feedback with us on how it can be improved during our consultation period, which closes in June. I'd also like to draw your attention to the March 2026 issue of RCDSO Connect, our new magazine. It's available on our website, and we'll share a link with you in the chat. The March issue includes articles that explore access to care, continuing education, and the role of professionalism and trust in everyday dental practice. Taken together, this really reinforces that professionalism isn't just about meeting expectations or complying with standards. It's about how care is experienced by patients, particularly those who face longstanding barriers or have complex needs. And that idea leads us directly into tonight's session. Over the next hour, we will explore how dental teams can build trust, adapt care, and respond thoughtfully to patient experiences. We'll start the presentation, followed by a moderated panel discussion grounded in lived experience and practical examples. As always, please feel free to submit your questions throughout the session. We'll do our best to answer as many as possible, and we'll review any questions that we can't answer. So before we start tonight's discussion, I'd just like to recognize the privilege of gathering online this evening by sharing a land acknowledgement. And this acknowledgement is going to be rooted in the physical location where the RCDSO building is located. So the RCDSO is on the traditional lands of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. These traditional lands are known to some as Toronto. Toronto is covered by Treaty 13 with the Mississaugas of the Credit, and it's home to many diverse First Nations, Inuit, and Métis peoples from across Turtle Island. The land is also part of the Dish with One Spoon territory, a treaty between allied nations to peaceably care and share the land. We accept our responsibility to each other and this land we live and work on in a spirit of peace, friendship, and respect. We're committed to actively supporting the necessary work towards truth, reconciliation, and equity. And we embrace our role in regulating dentists, in protecting the public interest, and strengthening our partnerships with Indigenous communities to advance access to safe and equitable oral health care. So we'll get underway in a few moments, but I'd like to first offer a brief introduction of both Lara Timler and Dr. Noha Goma. Lara Timler will kick off tonight's session with a presentation. Lara is the academic coordinator for the dental hygiene program at Fanshawe College. She is a member of ODHA's Long-Term Care Advisory Committee. Lara is also a founding board member and current chair of the London Community Dental Alliance, which operates London's first and only not-for-profit dental clinic serving those experiencing low income and homelessness. She's an outgoing director with the Canadian Society for Disability and Oral Health, finishing her term as the chair of the Student Representation Committee in 2025. In 2024, Lara was the recipient of CDHA's Award of Merit for regularly contributing to the dental hygiene profession and her community in a selfless, professional manner. So welcome to Lara. Next up, Dr. Noha Goma will moderate tonight's panel discussion. Dr. Goma is an associate professor of oral medicine and the associate director for research at Schulich Dentistry, Western University. She serves on the RCDSO Council as Western University's appointed academic member. Her research lab centers on evaluating oral health interventions and policies with a focus on determining their impact on medically complex and underserved populations. In addition, she leads research on professionalism in dentistry and dental workforce outcomes, reflecting a commitment to strengthening professional practice. Dr. Goma serves on several governance and leadership roles in Canada and internationally. She is the Vice President of the Canadian Association for Dental Research and is a member of the Scientific Advisory Group of the Office of the Chief Dental Officer of Canada. More recently, she was appointed as Vice Chair of the Research Committee at the National Dental Examining Board of Canada. We have a great program tonight. A warm welcome to all of our panelists and Dr. Goma and Lara. And Lara, I will turn things over to you.
Great. Good evening, everyone. Thank you for the warm introduction, Andrea. I'm thrilled to be here this evening and to take part in this really important discussion. Before we begin, I want to briefly frame what this discussion is all about this evening. As the Canadian Dental Care Plan expands access, more oral health care professionals than ever before will be caring for patients who have gone years or even decades without treatment and who may present with complex medical, social, and disability needs. Tonight's session is about acknowledging that many of our patients are arriving with more complexity than ever before. Financial stress, fear, disability, unstable housing, long gaps in care, or past difficult experiences in healthcare. The question is, what are small, practical adjustments can we do to build trust, deliver better care, and to do so in ways that are realistic and sustainable for practice? And what does compassionate, effective care look like in these circumstances? How do dental teams adapt their approach in ways that are inclusive and sustainable for providers themselves? My role in the next few minutes is to introduce the Wright Clinic as one example of a community-based integrated model of care, and to define a few key concepts that help frame the rest of today's discussion, including health equity, social determinants of health, trauma-informed care, and the importance of seeing this work as relational before it's clinical. And while we will be presenting our material tonight through the example of the Wright Clinic as a community-based model of care, I hope you'll consider how many of these principles are already being applied in your own practice. This is presented not as a model that every practice should replicate. It's an example that helps us see what barriers to care can look like and what practical responses can really make a difference. To help ground that discussion, I'm going to begin with a few shared definitions and then briefly show how the Wright Clinic puts these ideas into practice. The RCDSO, next slide, please. There we go. I think it's the one with the practical language here. One second. There we go. So the RCDSO's Foundations of Professionalism outlines these key concepts as they relate to navigating clinical practice and the ethical complexities that often arise when providing oral health care. These terms can sound abstract, but most of us have seen the realities behind them in practice. Things like missed appointments, extreme anxiety, delayed treatment, or patients who are disengaging when they feel overwhelmed. And dentists work with these concepts every day. Dentists have also found creative ways to help patients be able to receive care, especially those who arrive with fear, instability, or barriers. Health equity is a crucial concept for all of us in healthcare, and it often means not necessarily treating people the same, but appreciating that our patients come into our practices with sometimes complex histories and fears. And that equitable access may mean going beyond the dental chair to ensure that they have the access to services that they need. The social determinants of health underpin our experiences, access, and health outcomes, considering the different social, economic, and political forces at play, and how they translate to access to care is important when meeting our patients where they are and understanding their health and social needs. Trauma-informed care is an approach much like routine precautions in infection prevention and control. We don't need to know a patient's history in order to create a calmer, safer, and more predictable care experience. Dentists already do this when they adjust their communication, their pacing, and provide reassurance to help patients manage their fears and anxieties in a dental office. Lastly, culturally safe care is inclusive care, appreciating differences and providing tailored supports when needed, whether it's a sign language interpreter or help navigating CDCP enrollment. Culturally safe care is not about having an expert knowledge of every culture, and more about avoiding assumptions, communicating respectfully, and creating enough trust that patients feel safe asking questions and taking part in decisions about their care. So, for oral healthcare providers, it's important to understand how these concepts can influence real clinical decisions, how we explain treatment, how we obtain informed consent, how we recognize when a person may need extra support, and how we adjust our approach so the patient can receive the care that they need. This is especially important for patients who have gone years without treatment or present with multiple barriers. For dentists and members of the dental team, equity isn't an abstract public health concept external to practice. It shows up chairside every day. Every team member in the office contributes to a safer, more coordinated patient experience. Communication, pacing, and patient experience often determine whether clinical care can proceed. How we support the principles of health equity can include being fully present, providing clear information in a format the patient understands, encouraging shared decision making, creating safe environments, taking extra time when required, and treating everyone with kindness, compassion, and respect. And these ideas are not just ethical ideals. They really do shape how care is organized and delivered. And with that in mind, I want to briefly introduce the Wright Clinic because it's not simply a place where dental treatment happens, but a model designed around the understanding that for many patients, relationship, safety, and trust must come first before treatment can succeed. The Wright Clinic opened in 2021 for the purpose of relieving poverty and promoting health equity by operating a community-based dental clinic. The clinic's namesake, Dr. Ken Wright, was the catalyst to encourage a dedicated group of oral health, social service, and community advocates to establish a standalone dental clinic in London. The Wright Clinic makes it possible for adults in London who face barriers such as low income and housing insecurity to access the oral health care that they need. It provides a full spectrum of oral health services to adults aged 18 and older who are low income, have minimal insurance through a government plan, or who have no dental insurance at all. Our model is unique in Canada by operating with a full complement of paid staff, including dental assistants, dental hygienists, and dentists, offering care Monday through Friday, 50 weeks out of the year. Our dedicated staff are complemented by an equally dedicated team of volunteer dentists and specialists, And through their generosity, we're able to provide a welcoming dental home and access to specialty care, including periodontics, prosthodontics, complex surgery, and endodontics that would otherwise remain inaccessible. Even more importantly, the clinic is a hub of learning, inspiring future generations of dental assistants, dental hygienists, and dentists of what compassionate, person-centered care looks like in practice. The clinic is managed by the London Community Dental Alliance, whose board brings together expertise from dentistry, public health, social services, primary care, and education. That multidisciplinary leadership is really important because it really reflects that barriers to oral health are multifaceted and they certainly require a coordinated approach. Most practices are not going to look like the Wright Clinic, and they don't need to. The value of this example is not the model itself, but the practical principles behind it. Building trust, taking time, offering flexibility where possible, and connecting patients to support when needed. It's not about adding unlimited time or uncompensated care. It's about those small adjustments that can make care more effective, safer, and more sustainable for both patients and providers. Understanding that barriers outside the operatory often determine what happens inside it. The Wright Clinic is the anchor point of a deliberate partnership that blends people, funding, and capacity building across oral health, primary care, social service, and academic sectors. The point is not simply that multiple services are nearby. The point is that staffing, training, education, and referral pathways are co-owned so that clients experience one seamless service rather than parallel programs under the same roof. This is what makes this an integrated model rather than just a co-located one. In terms of shared human resources, the London Intercommunity Health Centre supports key functions for us such as communications and HR expertise. A shared social worker funded through Glencairn Community Resource Centre can provide on-site system navigation and access to harm reduction counselling and supports team-based care planning as well. Students from Fanshawe and Western complete supervised clinical rotations that strengthen service capacity and create an equity-oriented workforce pipeline. In terms of shared clients and bidirectional referrals, this can include things like warm handoffs. Our clinic staff can walk a client directly downstairs to Glencairn for help with housing, food security, or other supports, while the resource center staff can refer participants when oral health issues emerge. And this reduces the burden on the patient to navigate a fragmented system alone. The Wright Clinic is also a catalyst for care within the larger oral healthcare community in Middlesex, London. The clinic's partnerships support training in trauma-informed and harm reduction approaches while giving students direct exposure to interprofessional, equity-oriented practice. Partnerships with the Middlesex London Health Unit, Glencairn, Fanshawe, Western University, volunteer dentists, and the larger dental community are all central to our sustainability, access, and building provider capacity. In a private practice setting, integrated care can be simplified, and it may look like clear team communication, a list of community agencies for additional support, and straightforward referral or follow-up steps that make it easier for patients to continue their care. The clinic is fortunate to have our evaluator conduct annual client feedback surveys to better understand the needs and barriers faced by our patients. Findings from our most recent survey show that 91% of our clients reported previously facing barriers, mainly cost and dental anxiety, and many have gone years without care, with more than half not seeing a dentist in over 2 years. This matters because oral health inequity is more than just addressing financial barriers, although those are substantial. Patients may also need encouragement, extra time, flexibility, help navigating services, and support with life circumstances that affect whether treatment is possible. Connecting our clients to services outside of dentistry is necessary to address the often intersecting forces that shape people's ability to achieve health and well-being. Dr. Ali, Dr. Manny, and Teresa will be giving us some tangible examples of how this can work in practice a little later on. According to our 2025 impact report, the clinic served almost 900 clients, delivered almost 7,000 procedures, completed over 3,000 appointments, and restored 1,500 teeth. 87% of surveyed respondents reported improved oral health, oral hygiene, confidence, and improved quality of life. 40% of those clients chose the clinic instead of the emergency room, providing significant cost savings to our healthcare system as well. The clinic reports 1.1 million in dental care provided, with 26 volunteer clinicians contributing 540 hours and 175 students gaining experience over the past year. Our clients frequently describe the clinic as welcoming, non-judgmental, compassionate, and life-changing. For dentists, the takeaway is that not every practice is going to look like the Wright Clinic. However, our model helps visualize what the RCDSO outlines under professionalism: creating safe environments, respecting autonomy, promoting equitable access, and taking reasonable and sustainable steps to address the determinants of health. And this is going to look different in different settings. One of the ways that that approach becomes sustainable is by making it visible to the next generation of clinicians. At the Wright Clinic, students are an important part of our model because they gain firsthand experience in what those reasonable, practical adaptations can look like in real patient care. Dental students are an important part of the Wright Clinic's model because they gain exposure to a broad range of patient needs and care situations. And this creates value not only for students, but for our staff and patients as well. Students learn adaptability and communication, staff have opportunities to participate in mentorship and reflect on practice, and patients benefit from a care environment that encourages time, attention, and trust. In this short video, 2 fourth-year dental students share what they learned while working with an anxious patient this past semester, and how that experience shaped their thinking about effective patient care.
So my name is Rashmi. I'm a 4th-year student at Schulich School of Dentistry and Medicine.
My name is Arma Mustafi. I'm also a 4th-year dental student at Schulich Western University.
So we're here today to kind of talk about our experience that we had at the Wright Clinic. So the Wright Clinic is basically almost a community clinic that serves a lot of the underserved population in the London area. So it provides that care for people that usually it's like almost like their last resort, where they're finally reaching out for the care that they need. And the Wright Clinic offers that service to those patients in the area.
Yeah, so today we're just going to talk about our experience that we had with one of the patients. So we had an emergency come in. This was a patient, a long-term patient of the clinic that was in pain because of a grossly carious wisdom tooth, to be exact, this 2-8. That was getting more broken down as time went by. So the description that the staff gave us was the fact that he wasn't able to sleep for 2 days because of the pain.
Patient did sit down in the chair. One of the main things that I think really helped in that experience was finding common ground to discuss with the patient. So the patient had certain gibbets on their crocs, and you can see Dr. Artistani, who was covering us, identified that there was a Manchester gibbet, and we started talking about soccer, finding common ground there. They had Jordans on gibbet, so we started talking about shoes and finding common ground there, where the patient started to feel more comfortable with us, not as dentists or dental students, but just more as people. And then you can see that that allowed for more communication in the actual dental procedure afterwards.
Absolutely. And then, so like throughout the treatment, we kind of did the chief complaint, history of chief complaint, the medical history updates, and all of those. And then the patient was telling that he's taking over-the-counter medications to subside the pain, but unfortunately nothing is helping. He had been sleep deprived for 2 nights when he came in. So this is a patient that knows that he needs to get the teeth out, but you could see that he's just, there's that limitation that's kind of like inhibiting him from getting that done. And then throughout the whole clinic, me and Rashmi, we both made sure to kind of let the patient know that we're here for him at the end of the day. He's always going to be in control. We asked him about his fears, what was his source of, what kind of like triggers his fear. Patient did mention that he's scared of the needles. So we're like, okay, so what we could do is probably we can like numb up the area, we'll take the time, we'll go step by step, and then at any point, if you think that you cannot take this anymore, we can stop. We did that, and then he further explained that he also is scared of the fact that the back of his throat feels numb sometimes. Where in that spot, kind of like Dr. Ardestani came in and he said that, listen, like I understand that's like a phobia of yours, but rest assured, know that the breathing, you can still breathe through your nose. The area is not affected, so that's just so you know, you're fine. And then at that moment, you could almost see like a aha moment in the patient. And I was like, really? So like that's the scenario. So it really like makes taking the time to like get to know the patient.
Music, he really liked Justin Bieber, like
song,
playlist. So when we were actually doing the extraction itself, the whole time we were all just humming the whole like song, and it made it more comfortable.
And the support staff at the Wright Clinic, all of them, they came in just to make him feel at ease. The front desk, the dental assistants, everybody was assuring him, someone was holding his hand, and yeah, everyone was just really there for him. Yeah. And I think it was a really good experience for the patient.
Yeah. And then once he did get the extraction done and realized that okay, it wasn't that bad, it gave that positive experience, not just the procedure itself, the whole experience. And then that positive experience hopefully is going to like snowball into him thinking that the dental clinic and oral health is more of a positive experience. And then hopefully we can like break that barrier where right now I feel that anxiety was causing an avoidance, and then that avoidance led to worse dental issues. Those dental issues needed another procedure. So hopefully it breaks that chain of dental issues, avoidance, dental issues, avoidance.
Absolutely.
So then now if you realize, okay, I can do this, I did this hard procedure where everyone said it was going to be super difficult getting a wisdom tooth out, but I was able to do it. So now let me take the time and I'll come back, I'll do my dental.
Okay, great. So building on those incredible insights, next we're going to have our moderator, Dr. Noha Goma, facilitate a discussion about small, realistic actions we can all take in our practices towards safe and inclusive care.
Thank you very much, Laura, for an informative presentation. Feeling purple and proud here of our Schulich Dentistry students and their work at the Wright Clinic. So thanks for sharing that. So as we move into our panel discussion, Laura will be also joined by other panelists. I'm very pleased to welcome Dr. Ali Ardestani, Assistant Clinical Professor at Western University and a practicing dentist committed to accessible inclusive care. Dr. Manny Friedman, part-time in private practice and volunteer for endodontic care at the Wright Clinic, and Teresa Pasquino, office manager at the Wright Clinic. Welcome everyone, and thank you for joining us for this panel. So after Laura has given us an excellent background on understanding and managing barriers to accessing oral health care, my question to each of you is, can you share some examples of how you have incorporated patient needs in meaningful or impactful ways? And I will start with you, Ali.
Thank you, Noah. Hello, everyone. Actually, that's a really great question. I think in our practice, we try to approach patient needs through a patient-centered lens. More specifically, what we describe it as a biopsychosocial model of care. What we see quite often is that the patient do not just come in with the clinical issue. They are also dealing with a range of practical and social barriers that affect their ability to access and stay engaged in care. For example, on the physical side, things like mobility limitation, transportation challenges can significantly impact whether a patient are even able to attend appointment consistently. And I think sometimes these barriers are underestimated, but they are really shape outcome in practice. So at the same time, the psychosocial component is just as important. Many patients coming with anxiety, past negative experience, or limited social support, which can affect trust and treatment adherence. So from a wider perspective, we know that the factors like social isolation and reduced support system are associated with the poorer health outcomes. So in response, we focus on creating an environment through active listening, clear communication, and continuity of care. So this helps us to build and improve engagement over the time. So I think this is really where a team-based approach becomes essential. So I think Teresa could share some practical example of how we implement this at our clinic. Thank you.
Thank you very much, Ali and Dr. Goma. I want to share a couple of examples today of two patients that come to mind. One patient was a patient who was blind. He had no local family or support system, and he was very independent. He was able to take the bus on his own and complete many tasks on his own. The problem was that he had never visited the Wright Clinic before and needed assistance to guide him into the office. This part of the journey was important for him. To come from the bus stop to our office was a real challenge. Rather than seeing that as a limitation, we worked with him to find a simple solution. We decided that he would call us when he was close to the clinic, and a staff member would go outside and guide him into the clinic. For him, it removed a major barrier. It also allowed him to access care with confidence. Another patient we see regularly in the clinic is quite socially isolated. She has no close family or friends. Around the holidays, one of our staff members was talking with her, asking just casually about plans or what was happening during the holidays for her. She shared with our staff member that she had no family or friends and would be spending Christmas alone. As a team, we got together and we provided her with a small gift. When we gave it to her, she was visibly emotional. She had not expected it, and it meant a great deal to her. Experiences like this remind us that sometimes it's small, thoughtful adjustments and genuine attention to our patients' lives that can shape how they feel about care and why they return.
Thank you, Dr. Friedman.
Thank you very much, and good evening, everyone. I'd like to approach this from a slightly different aspect, and this is more personal than what we need to do on a practice basis. A patient's first impression of our office is probably the most important thing when it comes to developing trust with them. The reception area should project a welcoming ambience to whomever walks into the room. And the individuals welcoming the patient and/or caregiver must exude compassion and have a welcoming demeanor. Patients with disabilities should be treated with compassion and a caring attitude. One of the most difficult things, certainly in Canada and the US, is access to care for individuals with disabilities. Personally, I'm going to relate a story about my own personal bias when it comes to treating individuals with disabilities. When I first came to Canada, my job was Director of Dentistry in a long-term care facility for developmentally challenged adults. One of the individuals in the facility was a young lady who had severe behavioral disorders and was placed in a timeout room on a regular basis. We were treating at the time, this goes back to 1987, about 600 residents in the facility. The caregiver for this young lady brought her to the dental office and requested that I try and do something for her appearance. She had a severe overjet and her upper anterior teeth literally were jutting out horizontally. My first thought was, this individual, is it really important to her that she has orthodontic treatment? Mistake number one on my behalf. Anyway, after a couple requests, I said, okay, I'll go ahead and we'll do the orthodontics for this young lady on the proviso that you do a psych evaluation for her before, during, and after treatment. She was referred to an orthodontist in London who put braces on, and literally the day after the braces were put onto her teeth, her visits to the timeout room decreased considerably. However, she still wanted to go into the timeout room, and the reason being is there was a one-way mirror in the timeout room, And she wanted to have a look at herself all the time because she really enjoyed having the braces. Not only that, her behaviors decreased considerably. The take-home message for me was that I came into a long-term care facility. I had my own biases. And the question that I would pose to everyone listening to this is relook at your own biases if you have them, and a lot of you probably don't. But we need to see individuals with disabilities from their point of view, and they all have their own self-image, which is as important as our image for us. And from this experience, it literally changed my attitude to providing care for individuals with disabilities. One other example, a young man had missing anterior teeth, and I made him a Maryland bridge. When I tried the bridge in and showed him in a mirror, he got so excited. This man had a grand mal seizure in the chair. Again, they have excitement, they have needs like anyone else. And I encourage everyone to put yourself in their shoes when we're looking at individuals that require care of this sort.
Thank you, Dr. Friedman. Thank you all for sharing your valuable experiences. And my next question is back to you, Lara, and also Teresa. So, Lara, your presentation touched on the social determinants of health, which are defined as the broad range of personal, social, environmental, and structural factors that determine health. To elaborate, they would include conditions in which we are all born, grow, live and work, and even age, and they extend to policies and systems that shape everyday life conditions. So my question to you is, how does the Wright Clinic address the social determinants of health when planning care?
Great, thanks, Dr. Goma. And so at the Wright Clinic, when we're thinking about the social determinants of health and when we're trying to find creative ways to address them, often it means that barriers to care are, multifaceted, as I mentioned earlier. And oftentimes things are kind of influenced by difficulty navigating systems. And so systems in particular, like the CDCP, and I'm sure everybody on this webinar has witnessed this in some form or another. So using CDCP as one specific example of how we kind of really support our patients to access, because again, this is the first time in Canada's history that we've had such an amazing investment in oral health care from the federal government. And so this investment is really intended to help increase access. However, through our experience at the clinic, because a lot of our clients and patients, they have so many barriers. So financial is often the most significant one. But as Dr. Ali mentioned, there's many other barriers. And so what this looks like at the clinic is that we work with community agencies such as the London Intercommunity Health Centre to help patients enroll and complete their CDCP enrollment, oftentimes ideally before they even come into the office for treatment. And sometimes that looks like not just assistance in terms of filing and applying for CDCP, but oftentimes for a lot of our clients, it also means filing their income tax. And in terms of CDCP, because you have to, file your income tax, it also may unlock a lot of those other benefits that low-income folks may not have access to because they haven't filed income tax in such a long time. We've also hosted a CDCP enrollment blitz at the clinic, so clients can get support on site and be ready for care by their next appointment. And again, it just kind of streamlines things. It really helps our front desk staff. It helps the patients feel supported and know that they do have supports, especially if they may have challenges using the internet or reading complex forms and things like that. And so relating that back to private practice, the kind of takeaway that you may want to think about is that you don't need to recreate a clinic model that's based in the community, but really trying to take a look at your practice and think about small ways to reduce friction for patients. And really, realistically, it might look like knowing where to refer someone for help with CDCP enrollment, maybe having some of your front desk staff provide more of that simple navigation support, or just simply identifying some patients that may need that extra help before their next appointment. So oftentimes those small things can really make dental care much more accessible. And sometimes addressing social determinants of health and dentistry is just about making that path to care just a little easier to navigate.
Thank you very much, Lara. Teresa, would you like to add to that?
Yes, absolutely, I would. Thank you. When we're planning care, we try to look beyond the procedure itself and consider what happens after the patient leaves the clinic. For example, we see patients, especially a lot more now with CDCP, who have not seen a dentist for a very long time and require multiple extractions. Recovery can be very difficult for someone who does not have access to soft food. We ask clients specific questions. We ask them, do you have access to soft food? Do they have the means to obtain it? And if not, we look for ways to support them. The Wright Clinic is very fortunate to be connected to a community center with a food bank. When we do extractions, we provide our patients with a package of soft food, including soups and yogurts, to get them through the next few days and to help them support the immediate recovery period. Access to food and financial resources are key social determinants of health. If those needs aren't met, it directly affects healing, comfort, and whether treatment is ultimately successful. So for us, it's really just about recognizing those factors and building support into the care plan. The patients are not only treated, but able to recover successfully.
Thank you. Thank you both. It's really great to see real-world examples of how the social determinants of health are incorporated into practice. And my next question is to Dr. Ali and Dr. Manny. We've heard Lara speak about trauma-informed care being relational before it is clinical. So how does this show up in your day-to-day practice, and how have you balanced that relational approach with the realities of accessibility and sustainable business models?
Thank you again, Noah. When I think about your question, actually, I remember a case in our clinic, an older adult who hadn't received a dental treatment for decades, with a history of significant dental trauma and multiple unsuccessful attempts at care. She would often present, but she wasn't able to proceed with any treatment. So before I seeing her, I reviewed the previous note. And it was clear that the many attempts had focused on the delivering of care, but the underlying barrier, trust, had not yet been addressed. So when she came for what became our first meaningful appointment, she was visibly anxious. And she said to me, "Doctor, are you going to do something to my teeth today?" And my response was like, hi, my name is Dr. Ali, and I'm your dentist today. No, I'm not going to do any treatment for you. I just want to know you. And if you're comfortable, we can talk about your oral health after that. That moment was shocking for her and changed her reaction and changed her body language. She became more relaxed and she breathed deeply, and she started become more engaging. And for the first time, we were actually able to connect to each other. In this session, there was no exam, no explorer, no instrument, just a conversation. But in reality, that was probably the most important part and productive part of her care. She booked another session. She came after that. And at the next appointment, she began to share her past experience, childhood dental trauma, fear, anxiety that had built up over many years for her. And I think there was the trauma-informed care become very practical. We have to show to patients that they are in control. They matter. And this is a space where we want to understand them, not just treat them. So in many ways, I use principles similar to pediatric dentistry, like clear communication, predictability, and giving the patient control, but always in a way that was respectful and appropriate for them. So when we move forward with the treatment, everything was done for her gently. topical, giving her time, followed by slow injection and profound anesthesia achieved. And her reaction was very telling. She said, I didn't know it could be like this, doctor. So I think that is really highlights the impact of relational approach because once the trust established, patients who previously couldn't tolerate a care can actually move forward in a very positive way. So I would say that relational care isn't separated from clinical care. It's actually what makes clinical care possible, especially in challenges cases. So just to add, this is not one-time success for me. I'm still seeing this patient regularly. Matter of fact, I saw her last week, and we've been fortunate to build the trust and relationship and continue moving forward with her care.
Thank you, Ali. Manny?
I think Dr. Ali has covered pretty much everything that one needs to with regards to trust. If you can build trust with your patient, then you've won the game. And I think one of the other things that I think one needs to do is if an individual has a caregiver, talk to the caregiver and get information from them what you can do to make that individual's experience more comfortable and a little bit better. I'd like to digress now to some clinical cases of how we can integrate this into a regular day-to-day clinical practice. And if I could have the first slide, it shows this young lady was involved in a motor car accident and she literally is disabled and has this super exotic wheelchair and can turn it into a bed. And in actual fact, I was able to treat Heather, who gave us permission to use her photograph. She was quite happy to have it done. And she came to the office, manipulated her chair, and all we had to do to treat her in the office was to extend the vacuum and suction and air lines so that we could actually work on her in a regular operatory. The second picture actually shows me providing care for her in the operatory where we have actually I've got an operating microscope. Wrong picture. I have an operating microscope that we were working on her, and I was able to provide endodontic treatment for her. And in addition, in the same office, she's had prosto and perio treatment done. So if we really put our minds to it, we can treat any individual that is able to come into our office. The next picture is of a young man who has a condition called FOP, fibrodysplasia ossificans progressiva. This is a severe disease, if you want for a better term. And the story with this young man was he could not get dental care anywhere in the Toronto area for 2 years. My brother, Clive, who is very involved with patients with this problem, asked if I would treat him. And I said, I know nothing about it, but if you tell me what to do, I'll do it. What I want to show you is you can see there's the beige pack or that we have underneath his body provides support for this man. What happens to him is if he traumatizes his muscle, it turns to bone, and he can barely move his neck. His body is rigid, but we were able to work on him. We had a time limit of about 20 minutes, and yet we made him as comfortable as possible. We spoke to his mother, who told us what we can do to help treat him. So I've just included these because I think each and every dentist has the ability to do this. Have nothing special, yet with a little bit of help and coaching, and we managed to treat a person who couldn't get treatment for over 2 years. So to fall back, I'd like to appeal to everyone, consider the individuals that are coming into your office and take on a few more. And the good feeling that you get after you've provided treatment is worth more than any financial compensation that you can get.
Thank you very much. Great insights. Thank you all. So now my question is to all of today's panelists. Just in a couple of minutes, can you speak, if you were speaking to a colleague, what is one concrete thing that you would advise them to do that could make a meaningful difference? And I will start with Ali.
Actually, what we are currently seeing in the practice is that the more patients are re-engaging with the dental system after a long gap in care. Many of these patients are very motivated to receive care, but they don't often benefit, they do often benefit from a slightly different approach, particularly when it comes to communication, trust building, and how we pace treatment. This is very common. Canadian data shows that the approximately two-thirds of individuals have been exposed at least one traumatic event in their lifetime, and around 7 to 8% experience significant symptoms consistent with the PTSD. So if I were speaking to a colleague, one practical thing that I would suggest is that start small, but start intentionally. For example, consider incorporating even one of these patients into your schedule, approaching that case with a little bit more flexibility, allowing a bit more time in the initial visit to better understand the patient background, their concern, and previous experience, and then moving forward with the treatment planning. From our experience at Wright Clinic, using the structured, patient-centered framework can make this much more manageable and consistent. So I think it's important to be realistic. Initially, this approach maybe require more time and it not seem as efficient and or profitable as a traditional model of care. But over the time, we have seen that the patient often become more engaged, more consistent with follow-up, and better integrated into the practice. You will see, and you start to see fewer missed appointments and improved treatment acceptance and stronger continuity of care. So if more of us willing to take a step, even on a small step and a small scale, I think we can collectively make a meaningful difference in improving the access for a patient who might otherwise remain untreated.
Thank you, Ali. Manny?
I think if I've got to put a couple points here is the one thing I would say is expand your boundaries. Try and move out of your comfort zone, and you'll find that you're able to achieve something that you didn't think possible. I was on a mission to Guatemala last year. My primary practice in London, I just do endodontics. I'm not a specialist. I restrict to endo, but we went to Guatemala and we were treating young children from age 3 to about 10. And in 1 week, I extracted more teeth and treated, as I say, more diseased teeth in 1 week than I've done in the last 50 years. However, at the end of that week, I left Guatemala with a feeling you just can't describe, the good feeling that you have. And I think we have a slide of the young children that we treated with Dr. Olaf Plotsky. Yeah. Dr. Plotsky is holding the picture he's holding is the kids that we treated, and you can see one is hugging. They each put a handprint on the sheet of paper with their name printed onto the hand. And I can't tell you, you just felt like crying because you felt so good that you'd done something. And this was clearly outside my area of expertise, yet we managed and did well. And I think that everyone should basically put yourself in a position where you're a little bit uncomfortable, but you choose to treat someone that you wouldn't have treated before.
Great advice. Thank you, Dr. Friedman. Teresa?
Thank you, Dr. Goma. As the clinic lead, I believe that it starts at the front desk. It starts with the first phone call to the clinic, and the training begins with the team. We invest in trauma-informed training to equip staff with the skills to recognize how prior experience, anxiety, mistrust, and broader social context can influence our patients' engagement. This supports a shift towards understanding the patient's behavior within the context of their lived experience, rather than viewing it in isolation. Fostering a supportive work environment that promotes safety, clear communication, and sustainable workloads. When the staff feel supported, they're happier. That relates to the patients. The patients can tell that the staff is comfortable, and it improves patient experience and the quality of care delivery.
Thank you, Teresa. And Lara, very briefly, because I know we're on time here, and I know the closing is for you.
So thanks, Dr. Goma. So I would just say, being able to provide mentorship and create opportunities for students and new grads, I think is a really amazing way that we can all make a difference and give back. And then lastly, very quickly, I would also say that volunteerism matters. And it's not just because it happens to be National Volunteer Week, but our volunteer dentists are so essential to our model. And if you have the capacity to volunteer, and not everybody does, it's, as Dr. Manny said, it's just incredibly rewarding, and you really get to push yourself outside of your kind of normal clinical boundaries perhaps, and get to meet people and help people that you wouldn't otherwise. So that would be my thought.
Thank you very much, Lara, and everyone. The discussions today were great. We know that this is not separate from our professional responsibilities. They're embedded within them. The RCDSO Foundations of Professionalism document, as you have referred to it, Lara, earlier in your talk, reminds us that professionalism is grounded in trust, respect, and a duty to put our patients first, and their interests. And that when we take the time to understand and respond to the broader structural and social contexts that shape our patients' health, we're actively living out those principles. So thank you to you all, our panelists, for this important conversation. And over to you, Andrea.
Thank you so much, everybody. And what a wonderful session. I really enjoyed all of the perspectives. And to Lara and Noha and all of our panelists, thank you so much for taking time out of your busy schedules to share your thoughts and experiences with us. And to everyone on the line, thank you so much for joining us. In terms of CE, you don't need to do a thing to get your CE certificate. We'll draw on our records from Zoom, and we'll get those certificates out to you by the end of next week. As always, if you have practice-related questions following tonight's discussion, please do consider reaching out to our practice advisory service. You can always also visit the RCDSO's website for a whole host of resources. I'd also like to note that RCDSO Council just met last week, and this is a really great way for all of you, our registrants, to stay informed. We do have a YouTube channel where we have recordings of past sessions. You can also watch us live stream. And then our RCDSO Connect sessions are also on YouTube. We have a special playlist of those sessions, and viewing those recordings is eligible for Category 3 CE points. They really do continue to be a valuable resource for ongoing learning. We hope you'll join us for future RCDSO Connect sessions. Our next one is coming up May 20th, and we'll be focused on infection prevention and control. Look out for your inbox for details on that. We'll be sharing that by email. Thank you once again so much for joining us, and enjoy the rest of your night.